Hi everyone, welcome back to Karlee's Farm. Today we're going to talk about dopamine. So to start with, we're going to talk about dopamine agonists, which are required for patients with Parkinson's disease who have low dopamine levels. So the main way that we increase dopamine levels in Parkinson's patients is to give them different medications. So we're going to talk first about levodopa. So levodopa is one of the main drugs used to treat Parkinson's disease. You take it orally. And what we need is to get levodopa across the blood-brain barrier where it can convert to dopamine. Now, what happens is levodopa, before it gets across the blood-brain barrier, can go through a couple of different processes to actually make less of it go through. So one of the things that can happen is levodopa can convert in the periphery to dopamine. Now for levodopa to convert to dopamine, we need a dopamine decarboxylase enzyme. So if levodopa is converted to dopamine in the periphery, dopamine as its own molecule is not able to cross the blood-brain barrier. Okay, so it's no use to us. It does not increase central dopamine levels. It only increases peripheral dopamine levels, which can cause nausea and vomiting, and is generally not a very nice thing. So what we do to prevent levodopa from turning into dopamine in the peripheries is to give a dopamine decarboxylase inhibitor, carbidopa or benserazide. Now, when you give levodopa always comes with one of these agents the product contains levodopa plus dopamine decarboxylase inhibitor, because we know we're trying to increase the amount of levodopa that can get across the blood-brain barrier. Now, obviously, we don't want our dopamine decarboxylase to be inhibited once we cross the blood-brain barrier, because we do want our levodopa to turn into dopamine. So these agents here, we give them with levodopa, but they can't cross the blood-brain barrier. So this just prevents peripheral conversion of levodopa to dopamine in the periphery. The other thing that can happen to levodopa to prevent it from getting to across the blood-brain barrier is that it can be broken down into 3-M-dopa, which is not important. It's an inactive molecule. And so what we want to do is prevent this breakdown, because we want to be able to increase the amount of levodopa available to cross the blood-brain barrier. And so a particular group of drugs called COMT inhibitors are able to inhibit that COMT enzyme to reduce the amount of levodopa being inactivated. The drug that does that is called entacapone. Entacapone is also unable to cross the blood-brain barrier, so this is just for working in the periphery. So these two groups of drugs, dopamine decarboxylase inhibitors and COMT inhibitors, are to increase the amount of peripheral levodopa available to cross the blood-brain barrier. Now, once levodopa crosses the blood-brain barrier, it can convert to dopamine. And two things can happen to dopamine in the brain. So dopamine can either be broken down by MAO-B, so monoamine oxidase, monoamine oxidase B, and that can be broken down to an inactive form, or it can be converted to another inactive form, again via COMT. So remember I said up here that we can use COMT inhibitors to prevent this COMT from converting levodopa to an inactive form. We can here, but we don't have any centrally acting COMT inhibitors in Australia, so we don't have that option here. What we can do is inhibit MAO-B. So these are monoamine oxidase inhibitors, rasagiline and saligiline, work centrally to increase the amount of central dopamine available for activity. Now, once we have dopamine in the brain, dopamine activates dopamine receptors, which in turn causes an effect. So the final way that we can influence dopamine activity is to have dopamine receptor agonists that go onto the dopamine receptors and mimic the action of dopamine or activate those receptors. And these are drugs such as apomorphine, pramipexole, and rotigotine. Now, these medications here, they are associated with a concerning side effect, which is a lack of impulse control. So some patients, if they do get that side effect, that can be really negatively influence their lives. And there are reports of patients who have unmanageable gambling and other impulse problems. So that can limit their effect. The other thing, of course, is anything where we are increasing the amount of dopamine in the brain, then we can get side effects such as agitation, delirium, etc. Dopamine in the periphery causes nausea and vomiting and other sort of dyskinesias, which we'll talk about when we do dopamine antagonism in a moment, but it can cause confusion, agitation, etc. So that's the main ways that we can increase dopamine to treat patients with Parkinson's disease. Stay tuned, and we're going to swap over and talk a little bit about dopamine antagonism. Okay, welcome back. So we're now going to talk about dopamine antagonists, which are most commonly used as antipsychotic agents to treat schizophrenia and delirium, agitation, severe psychosis, etc. So when you talk about dopamine antagonists as antipsychotics, there's essentially two big groups that they're broken into. And that is the typical antipsychotics and the atypical. So the typical ones are sort of the older generation, also sometimes called first generation antipsychotics. And so their activity is because of they antagonize D2, dopamine 2. So both groups do that. But these have a very high affinity and strong binding to dopamine antagonism, to the dopamine receptor, which it blocks. The atypical agents have a lower affinity comparatively to block the D2 receptors. These atypical agents usually also have other receptor activity. So commonly they can also affect both serotonin and noradrenaline, which means that we don't have to rely solely on their dopamine blocking activity, which means they've got less side effects than the typical agents. So the typical agents, because they've got a very strong affinity for dopamine block, they are associated with a particular group of side effects called EPSEs, or extrapyramidal side effects. And these are DAPT. So these are dystonias or involuntary movements. They're akathisias, which is an agitation, which can be a little bit difficult to differentiate between sort of a psychotic agitation and the way they're sort of told apart is that with an akathisia will get worse if you keep giving higher doses of antipsychotic, and will get better if you give less. A psychotic agitation obviously will get worse if you take drug away. P is for Parkinsonism, so bradykinesias, etc. So looking like a Parkinson's condition. And finally is tardive dyskinesias, which is a very sort of typical involuntary movement, usually of the face and tongue. Usually happens after sort of months or years of treatment, and it can be really difficult to reverse. In some cases can be irreversible. So these typical agents are really well known for causing these extrapyramidal side effects, which limits their use in practice. And these are drugs, you may have heard of some of these, like haloperidol. Droperidol is another one, very similar. Chlorpromazine, and there are a few others, quite a few others. Oops, sorry, it's off screen a little bit there. Bear with me. Here we go. The other group, so the atypical agents, have got much less EPSEs, which makes them much more useful in practice, but they are associated with metabolic side effects. So this is things like hyperlipidemia, increased risk of cardiovascular disease, weight gain, sexual dysfunction, etc. So this is much more these are much more metabolic in terms of their side effect profile. Now, both groups of drugs do have some side effects that they do have in common. So we might go here. Okay, so they can both increase the QT interval. So for patients who are on a few different agents that can increase the QT interval, or for patients who are on high doses of these drugs, they'll often need monitoring using an ECG. They can both cause NMS, which is neuroleptic malignant syndrome. Now, neuroleptic malignant syndrome is a very serious, can be fatal reaction to antipsychotics, which presents as a fever, usually some muscle rigidity, and is associated with an elevated creatinine kinase. So it's a really serious side effect. So these are, I didn't tell you. So some of the names of some of the typical agents are things like olanzapine, quetiapine, and there's a very special atypical antipsychotic called clozapine. Now, clozapine is considered the most effective antipsychotic, but it is restricted to refractory for patients who are refractory to first-line therapy, because it's associated with quite a few side effects that need monitoring. So there's a couple of things, but in particular, it can cause a neutropenia. So patients need to have regular full blood count and neutrophil count, and they have to have their neutrophils above a certain level in order to be able to continue therapy. It's also been associated with cardiomyopathy, so patients also get regular echoes to make sure that their cardiac function hasn't been affected. It can cause terrible constipation, so patients are counselled on managing their fluid intake and certain medications to make sure that they have regular bowel movements. And the other thing that we can do with clozapine is we can actually do therapeutic drug monitoring. So we can measure the amount of clozapine in somebody's blood to assess compliance and to sort of see whether they're in a therapeutic range, and if they're getting side effects in a therapeutic range, or if they're too high, etc. So that's the dopamine antagonists that are used as antipsychotics. Now, the final thing I just wanted to mention, so of course, remember, for patients who have Parkinson's disease who already have a dopamine deficiency, we should not be giving patients dopamine antagonists to those patients. Now, I just want to quickly mention a group of dopamine antagonists that are used for nausea and vomiting, okay? So they're one of the first line, most commonly used drug classes for nausea and vomiting. There's a couple that are very common. The first most common one is metoclopramide, and you may know it. Its brand name is Maxilon. It's very, very popular. You can get it. It's used for most nausea and vomiting. The other agent is a drug called domperidone. Now, domperidone is a really interesting drug because it does not cross the blood-brain barrier, which means that if you have a Parkinson's patient who has nausea and vomiting and requires a dopamine antagonist for therapy, this is the one that you will most commonly prescribe or you most safely prescribe, I guess, because it doesn't cross the blood-brain barrier. So it doesn't block dopamine receptors centrally, just peripherally in the gastrointestinal tract. And so I guess I'm just bringing these up because these are a very common medication that we prescribe, and you've got to be really careful because we know that they antagonize the dopamine receptors. And so for patients who have Parkinson's disease, you should avoid the dopamine antagonists for nausea and vomiting if possible. And there's another couple of ones, but they're much less commonly used. So that's dopamine in a nutshell. Thanks for joining me, and I'll see you next time.